risk in a managed care environment. We are excited to share this important information with you today, and we're happy that you can join us. This is certainly a very hot topic for folks, so I'm sure we'll have lots of questions after today's webinar. Before we get started, just a little bit of housekeeping. This webinar is being recorded and will be made available on the MCTAC site under the Small Business Initiative link, and that link can be found by clicking Trainings and then Business Best Practices. You'll find the link to last month's webinar on how to talk to your board of directors, as well as the slide decks from our regional forums that took place back in September for the rest of the state and just a couple weeks ago for New York City and Long Island. And we just want to remind you that the information being presented today is as up to date as of today. And we're going to ask you to use the chat box to type in your questions. We should have about 10 minutes at the end of today's webinar to answer other questions. You can also raise your hand and we can unmute your line at the end of the presentation. Okay, so let's get started. Okay, so what is MCTAC? MCTAC offers resources to all mental health and substance use disorder providers throughout New York State, and MCTAC's goal is to assist in the transition of managed care. This next slide shows you all of the MCTAC partners throughout the state. And here you have the partners for the Small Business Initiative, ASAP, NIAPRIS, the Coalition, and Families Together. And just a reminder about the Small Business Initiative, excuse me. Our job is to work with providers who have little or no experience billing Medicaid on the essentials for managed care readiness. And this webinar, along with last month's webinar, came out of the wants and needs that were expressed in our regional forums that we held. And we're also planning monthly webinars, so be on the lookout for those announcements from MCTAC. We are putting together a Small Business Initiative Office Hours webinar that's scheduled for January 23rd at noon. So we hope that our small business providers will join into that webinar and ask lots of questions related to anything managed care. And we're also putting a webinar together on partnering and linkages, so be on the lookout for emails from MCTAC and CTAC and myself, Daniela Labate, because we'll be sending those out to you as well. So again, I just want to remind participants to use the chat box to ask any questions as they come up during today's presentation. And I am going to now give you a little bit of background about our presenter. We're happy to have Whitney McGee Phelps with us. Whitney is from Greenberg Traurig, and over the last decade, she's focused her practice on both state and federal regulatory healthcare issues. She's specifically worked on managed care contracting, fraud and abuse in health and medical homes, and she's negotiated between MCOs, FQHCs, IPAs, providers, and others to draft and negotiate fee-for-service and risk-sharing arrangements. So we're happy to have her with us today and talk about risk management. Again, just one last reminder to use the chat box to type in your questions throughout the presentation. And then at the end of the presentation, if you want to have your line unmuted, just raise your hand and we'll be able to do that so that you can ask your question directly. So with that, I am going to I'm going to hand this over, rather, to Whitney so that she can start us off. Thanks, Whitney, and welcome.
Thank you so much, Daniela, and thank you, MCTAC, for putting this presentation together and for everybody for participating on the call. I hope we can have a lively question and answer session at the end, so I'm going to try and make sure to leave some time for everybody. I was asked to speak about the legal and liability issues that providers may be facing as they consider providing services to the Medicaid population, either as because they've never provided services to the Medicaid population before on a fee-for-service basis, or because they're new to the managed care environment. I'm going to try and give a little bit of background just to kind of set the stage. As most of you probably know, that the Medicaid program has been changed so that we are now in a mandatory Medicaid managed care environment. So everybody on Medicaid now is being put into a managed care plan. And for purposes of this presentation, I say the slides refer to an MCO or a managed care organization, and for purposes of this presentation, I'll just use the word plan. It's a little bit easier to say. All means the same thing. They've been licensed by the state to provide Medicaid benefits as an insurer. Really, as a health maintenance organization or a managed care organization, their legal responsibility is to provide a set of comprehensive services to Medicaid enrollees for a set fee or a premium. And the state likes this because it creates some predictability in their budget as opposed to fee-for-service where the amount of money could change and fluctuate. So with that said, I am going to focus on some of the legal and liability issues that a provider needs to think about as we move into this managed care environment. And here's a list of some of the things I'm going to focus on. Who is the contracting parties? What is credentialing and why do we have credentialing? What are some of the insurance obligations and indemnification obligations you might see in a contract with a managed care company or a plan? Some fraud and abuse obligations, quality assurance requirements, privacy and security under HIPAA, and also state law, and then some of the payment issues that could come into play as you contract with plans. So what is the kind of the flow of money I always think is important to think about? And as I said, the state contracts with plans or managed care organizations to provide this comprehensive set of benefits. That contract between the plan and the state is set. It's a we call it the model Medicaid contract. You can find it on the Department of Health website. It's an important document to understand and maybe something you want to look at. It's several hundreds of pages, but it does have a good index so you can kind of flip through areas where it may be relevant for you. And that is that's the relationship that determines how the flow of money goes from the state to the plan, the set premium it receives, and then all the obligations that the plans have to meet per the state's requirements. And it's important to understand what those obligations are because a lot of those obligations get passed down to the providers. And those are some of the obligations I'm going to be talking about today that as a provider of somebody in a plans network, you have to try and meet. So to help the plan meet its obligations that it has to the state. So who is the provider? The provider is the entity, the legal entity that holds the contract with the plan. Plans are only allowed to contract with certain entities in the state, either a licensed entity, a professional corporation, an independent practice association, or some of you may have heard of an accountable care organization, which is kind of a new standard that came into play with the ACA. And it is the entity that has the legal responsibility with to meet the obligations under the contract that it has with the plan. The employees are not necessarily, they may have to help the provider, the legal entity signing the contract, meet those obligations, but they aren't ultimately responsible for the contractual relationship. So the provider gets credentialed, and the credentialing is an important requirement from the plan's perspective because the plan has to make sure that the provider in its network is qualified to meet the obligations and to provide the services to its membership. You could think of this similar if some of you are enrolled in a Medicaid enrolled provider. Some of these qualifications are similar that the plan is going to require that you adhere to. Credentialing is a systematic approach to verify the qualifications of the person rendering the services. And the plan is going to, so they're looking at, is the person properly licensed? Have they had the proper training to provide the services? They're going to make sure that the provider is not an excluded individual from rendering Medicare and Medicaid services, so it's not on the list of excluded individuals or entities. It's not on the list for Social Security Administration data master list, death master list. Basically, it's not the person hasn't been disbarred or precluded from providing Medicare or Medicaid services. They also, credentialing is also kind of making sure that the person is just, properly qualified to provide those services. Credentialing occurs at the facility level, so if the agency needs to be credentialed, and then also at the individual licensed practitioner level. So if you have a social worker or something like that, the plan is going to do the credentialing of the individual social worker. Clearly, your employer or the agency that's being credentialed and holding the contract with the payer would ensure that its employees are credentialed and provide the information that the plans need in order to have the individual employees meeting the credentialing standards. Plans will not will not pay claims for any provider that is rendering services if the person has not been credentialed. State law does require that plans are efficient in credentialing providers, and so there is a set standard that they have to do this within a 90-day time frame. Credentialing is important from the plan's perspective, not only because it wants to make sure that the members in its network are qualified to provide services to the enrollees, but from a plan's perspective, it is the one area where they had exposure for medical malpractice liability. A general rule of thumb is that plans cannot be on the hook, so to speak, or liable for the malpractice of its network providers. The one area where case law does differ on this is if a plan is credentialing a provider that should not have been credentialed. So if there's evidence that there was harm to patients or that somebody wasn't properly licensed and the plan credentialed them anyway and there was some kind of malpractice incident, the plans can be on the hook for that. So plans do take seriously that they have properly credentialed members in their network, providers in their network. So what does it mean to be a provider in a plan's network? Providers can anticipate that they should be able to get a certain volume of business as a result of being in the network. Providers have to adhere to certain policies and procedures. Many of those policies and procedures come from the contract that the plan has with the state. The state says that plans have to have an adequate network, so they have to have providers in their network that are within 25 miles or 25 minutes of each enrollee's house. They have to make sure that the providers are accessible to the enrollees on a 24-hour basis, 7 days a week. That can be satisfied through a call service. They also have to make sure that certain cultural competence standards are met so the providers can meet the cultural and language specifications of the membership. And that certain kind of good practice follow-up care is met. So with respect to mental health and substance abuse, if somebody is admitted to an emergency room or an inpatient hospital for some kind of mental health or substance abuse diagnosis or incident, the plan has to make sure that there's a provider within the network that can meet that individual and follow up with that individual within 5 days of a request. So again, that's an obligation that the state imposes on the plan that the plan is going to ask the providers to be able to adhere to and meet. So plans are going to require and want to make sure that there is insurance in place and the providers have insurance, malpractice insurance, and also general liability insurance, so that if they get sued because of their network, that because of a provider in their network, that the provider has the ability to either indemnify the plan and or has the malpractice insurance to be able to meet the requirements to for any potential liability. Cybersecurity is another, sometimes another requirement. I'm not sure it's going to be something that's going to be effective for the small business arena, but it is often something that's becoming more and more commonplace as we're exchanging protected health information between plans and providers and between providers, and you see more and more data breaches come into play. This is something that you know, is kind of on the horizon. Indemnification, you know, you want to understand what your insurance limits are and understand if you have the ability to contractually provide for indemnification. Typically, plans are going to want you to indemnify them in the event that they are sued for some of the provider's negligence. You should know that in some cases it may be one-sided and the plan is going to require indemnification of the providers, but it's okay to ask for mutuality and that the plan would also indemnify you as the provider in the event that they did something that they shouldn't have done, and you want to be able to hold them responsible for it. So, fraud and abuse is another area of that, you know, I think you want to be aware of, and another area of risk for providers. As you've probably seen in the news, more and more the government is cracking down on Medicaid fraud. And fraud is defined as the intentional deception or misrepresentation made by a person. Abuse, however, though, is a much broader and more expansive definition, does not require intent, and really talks about, you know, incidences where providers' practices are inconsistent with sound fiscal, business, or medical practices that result in unnecessary costs to the Medicaid program. They're really wanting to make sure that providers are, you know, providing kind of clinical best practices, that services are medically necessary, that are being billed for, and that, you know, services are actually being provided that are being billed for. So abuse is an area where I think it's important to make sure that providers are properly documenting the services that they're being rendered, and you know, investigations will occur as the government is looking at potential areas of fraud and abuse. Plans are required to have a comprehensive fraud, waste, and abuse detection and prevention program in place at a special investigations unit. So they're looking to make sure that the providers in their network aren't engaging in any kind of fraud or abuse behavior. In addition, as a result of the Federal Deficit Reduction Act and part of the Affordable Care Act, providers that receive reimbursement on an annual basis of more than $500,000 from the Medicaid program, and that would include from a plan, that they also have a compliance program in place, and they have to annually certify that they have a compliance program in place. And part of that program is requiring that you educate and train your employees about the False Claims Act and also the federal and state whistleblower provisions. The Affordable Care Act, one of the big things that it did, it wasn't just about providing insurance and making sure everybody has health insurance, but a lot of what the ACA did was also strengthen the fraud and abuse provisions and imposed upon the government, and then also on the plans, an obligation to suspend payments to a provider if there was a credible allegation of fraud. And this has also been adopted by state statute now, so it applies in New York as well as on a federal level. A credible allegation is really any circumstantial evidence that would suggest that somebody is engaging in fraud or abuse. And these could come from a fraud hotline. The government, you know, looks at claims and they comb through claims data. It's called data mining to look for certain patterns of behavior that they think may be suspect or potentially problematic. As I talked about, the plans also have an obligation to have a compliance program in place, so they're also looking at claims data to make sure that there's no improper claims behavior or patterns that they can see. And there's also auditing requirements that plans have of their provider network. So the contract that the providers have with the plans will have obligations or allow the plans to be able to come in and audit and have access to your records to make sure that you're properly billing for the services that are being provided. The state may withhold payment if they have determined that a provider has engaged in abusive behavior, and they actually are obligated to withhold payment if there's a potential fraud allegation in play. So this is before there's ever been a final determination, but while they're kind of determining whether or not fraud has been in play, they will withhold payment, and that can have a significant impact to a provider, clearly because you're rendering services and you may not be getting paid for those until a final determination has been made. Some take the position that, you know, there's no fraud to the federal government if a plan is involved because, you know, the plan is getting a set premium from the government, and so how is this increasing payments to the federal government in any way? But plans premiums are set based on the cost that it renders every year, and so additional premiums or increases in premiums theoretically could come into play if they're paying for services that are not proper. And so the government has in essence said that fraud on a managed care plan is also fraud on the federal government, and thus plans have to make sure that they have the same obligations to basically withhold or stop payment if there's any fraud or abuse that they think potentially is credible. Another big area of concern for some providers is, and something that providers need to be aware of as they're billing for Medicaid and Medicare, is that the Affordable Care Act requires that providers must report and return any overpayments that it becomes aware of. Actually, the obligation is to return or report any overpayments within 60 days after it's been identified. An overpayment is defined as any funds which the person was not entitled to receive, either because they weren't eligible for the payment, maybe it wasn't medically necessary, they didn't meet the conditions for payment, or it's potentially some kind of kickback payment. So sometimes this could be, you know, fairly innocuous. You may have gotten double paid for something, and it was a mistake, really. But once you become aware of that mistake, you have to then return and notify, report, and return that payment. And that notification, report, and returning of the payment, the notice needs to really go to the plan and then potentially also to the Secretary, to the Department of Health or OMIG. Again, the importance of documenting the services you're providing, I can't emphasize that enough, is that you really document what you're doing in the record, and to make sure that the claim that you're submitting for the services that you're providing is properly is supported by the medical record. So, you know, plans will go back or the government could go back and look at your medical records for the services that you've billed to ensure that those are that they've been rendered and what you've rendered matches what was billed for. So again, I can't overemphasize the importance of documenting. Another area of concern that you want to be aware of is HIPAA, a federal statute that was enacted over a decade ago to protect the use and disclosure of protected health information, which is really any identifiable information of a member or a patient without disclosing it without their written authorization. There is an exception in HIPAA that allows the sharing of PHI or protected health information between a provider and between covered entities, and a covered entity is really a provider or a plan for the purposes of treatment, payment, or healthcare operations. So you can share PHI like a claim between a provider and a plan for purposes of getting paid without necessarily having to get the consent of the member. But this is something that you need to be aware of as you start submitting claims to plans for healthcare services. New York law does have more stringent rules, especially when it comes to kind of sensitive categories of information, so any HIV records or mental health records, alcohol and substance abuse records, you need the consent of the member to be able to share that information. Consent, typically, you can get consent at the time of the enrollment or as the patient comes to see you for the first time. That's typically the best time to get consent, is when they come to see you and you sign all those disclosure forms and the notice of privacy. And the Medicaid program also kind of requires, as person enrolls in Medicaid, as part of the application process, is they are allowing and they're consenting to the sharing of their information between the plans and the providers. Again, this is just something that you want to be careful of, make sure you're getting the proper consent, and be cognizant of the fact that there are specific rules that are in play and kind of more onerous consent rules in play when you're dealing with sharing what I call sensitive category information, so health records, mental health records, HIV records, and the like. HIPAA also requires that you have certain security protocols in place, and this is so that you can't be sending electronically protected health information without having proper safeguards in place. Examples of this might be that, sending information via email about a particular patient should be through a secured server. It's important that you educate your workforce about these privacy and security protections, so you're making sure that any information that is about a particular patient is properly secured and can't get into the wrong hands. Failure to adhere to the privacy and security standards can result in enforcement by the Office of Civil Rights, which is a department of the Department of Health and Human Services, the federal government. There's also state oversight of this. You'll probably have read in the paper more recently, for many, many years, there wasn't any enforcement of HIPAA. They were allowing providers and plans to kind of get in compliance, but as you see more and more HIPAA breaches and privacy breaches, they are starting to impose very large fines for the failure to secure public health or protected health information. There was also a fairly recent case. There's no private right of action, so an individual can't sue because their information has been disclosed improperly. So if my information was disclosed by an agency, I can't go out and sue that agency for disclosing that information. However, there was a recent case that said that the failure to meet the standards of HIPAA was the basis for a negligence action for inappropriately releasing medical records. Again, just the importance of understanding HIPAA and being able to make sure that you're not improperly disclosing information about patients that you're seeing. So some of the payment issues that you want to be aware of and keep in mind as you're negotiating with plans or contracting with plans for rendering services. Providers must submit claims timely or run the risk of not getting paid. The state has set a minimum standard that all claims must be submitted to a plan within 90 days of the date of service or the date of discharge. It's important to know that that's a minimum standard, so plans can't require you to submit claims less than 90 days. You can also ask for claims to be submitted in more than 90 days. So this is something that you would see in a contract. It's something that's negotiable. You can ask for more time to submit claims. But again, the longer you submit claims, then the longer it takes for you to actually get paid. So you really want to make sure that you have the abilities to submit claims, know how quickly you can submit claims from the date of service, and be able to meet whatever the contractual requirement is. State law does say that if you don't meet the timely filing requirement, plans still have to pay you unless they can show, well, let me put it this way, they can reject the claims if you don't submit a timely claim. So if you have a claim and you submit it and your contract says you have to submit within 90 days, if you submit that claim 120 days from the date of service, the plan can reject it because their computer systems are kind of set to meet, in many cases, the state standard of 90 or 120 days. That being said, so you'll get a rejection. That being said, you have the right to be able to resubmit that claim and get paid, provided that you do not have a kind of systematic or routine pattern of submitting late claims. If you have a systematic and routine pattern of submitting late claims, then the plan has the right to not pay you. But if you can show, hey, we usually submit our claims timely, then the plan has an obligation to pay you, and they'll submit payment after that. Sometimes you may find penalty provisions in the contract. Those are, again, negotiable. Plans do have the right to be able to penalize somebody for submitting claims late, but that is a negotiated provision, and they don't have an automatic right to be able to reduce the payment amount because you submit late. Plans are obligated and required to timely pay for claims. So claims that are submitted electronically have to be paid within 30 days. If it's a paper claim, they have to submit within 45. If they're late in submitting those claims, then interest automatically it gets tacked on. And if there are complaints or you can also complain if plans are not timely submitting or not timely paying for claims. And the Department of Financial Services, actually DFS, has jurisdiction over plans' payment of claims. They can investigate, and plans are also audited on a yearly basis, and fines. The fines actually are fairly large for the plans if they don't submit timely. So I think they've gotten pretty good about submitting timely claims. As new providers come into the system, sometimes there can be glitches. So it's important to look at and make sure and track that the claims you're paying, the claims that you're submitting, are being submitted timely within the contractual time frame, and then that you're getting paid timely. And so it's really important, specifically as small businesses, to really make sure you have some kind of process in place to kind of track when services are being rendered, when claims are being submitted, and when claims are being paid timely, and that this is kind of part of your revenue cycle management process, and that you're really following up with the plans if there are issues. You can have real big problems if you wait a long periods of time before kind of raising issues to the plans, and that's where it can get more tricky. The longer you wait from the date of service, clearly the harder it can be to clarify the services you rendered and make a case for why you're entitled to being paid. It's important to note too that plans have to submit claims or encounter data to the government. So all of the claims or encounters that you are billing for, the plans have to then turn around and submit to the state, actually on a bi-monthly basis. And if they don't, then they can be sanctioned a fairly hefty fee of $2,000 a day. And so another thing that sometimes plans may do is impose penalties if you are not getting encounter data or claims submitted to them. And again, these are all contractual provisions that you can push back on a little bit in the contract. So it's important to know that as you're negotiating contracts with a plan, that it's not a contract of adhesion. You don't have, it's not a take it or leave it arrangement. You have the ability to negotiate the provisions. It's important to know what those provisions are in the contract. And if there are things that you don't think you can adhere to or that you don't think you can meet, that you know, you ask for, you push back and ask for different provisions. If there is a dispute, ultimately you're going to go back to the contract, and how that dispute gets resolved will rest on what the contractual relationship is. The contract is, again, kind of the terms and conditions that set the relationship between you as the provider and the plan. Just like the plan's contract with the state sets the terms and conditions that the plan has to have, and that it's imposing, again, then downward to you. So in conclusion, I'm a little bit quicker than I guess I realized, but so hopefully we'll have some questions in the queue if people have questions, or you can start thinking about questions and you can raise your hand, and I believe Morgan will help answer them and send them to me. But it's important, again, to be truthful and accurate and complete in the information you provide to the plan. The plan's relying on the information that it gets from its providers, and that relates to the claims you're submitting as well as the credentialing information that you're providing to them. It's important that all the entities that are providing services for you as the agency and the licensed entity are properly you know, licensed, that they provide good quality service, and there aren't a lot of disputes or complaints about those providers, that you're documenting the services that are being rendered accurately and completely, that you're only billing for services that are being provided, and that the documentation, the records support the bills that are being provided, that you protect the information that you have about your patients, the claims and the medical records, and that you be careful about who you share that information with, within your organization as well as outside your organization, and that you make sure that you have some kind of security protocols in place in the event that you ever need to electronically send information about your patients to others outside of your organization, and within your organization. So with that, I think I'm going to conclude, and we have a little bit more than 10 minutes for questions, so hopefully there's some questions in the queue.
Thanks, Whitney. So we're actually going to take a minute or so to give folks an opportunity to chat in their questions. And remember, if you want to ask Whitney a question directly, please raise your hand, and Morgan, our friend at MCTAC, will help us unmute your line so that you can ask her. Okay. So our first question is, many of us have never had to do this before, and it feels a little overwhelming. What's the best way to get started?
I appreciate that's the perspective. I think you're not alone in feeling that it's a little overwhelming and daunting. I think that, you know, the first thing is to find out who who the payers are in your area. So each plan is licensed per county, and that information can be found on the Department of Health website. And I would recommend, reaching out to the plan and finding out how you can get a hold of their contract, their provider contract, and start looking at the provider contract, get familiar with the terms, and then kind of start thinking about the process that you want to, what you need to do to get a contract with that payer and move forward with providing services. So it's not as it's not as overwhelming and daunting as I think it might seem. I also think MCTAC has a ton of amazing, wonderful resources available to help providers as they start down this process.
Okay, thanks, Whitney. We have another question that is, where's the best place to learn about Medicaid laws and rules?
So that's a good question. I think the best place would really go to be the Department of Health website. Has on the left-hand side, I think there's Medicaid, and then there's also a tab for managed care, and you can look there for one. You can find the Medicaid model contract, which I talked to you about in the very beginning of my presentation, which is the contract between the plan and the state. You can also then look at the state actually also has a document called Provider Contract Guidelines, and that sets forth a lot of the state laws and gives citations for the state laws that govern the relationship between plans and providers. So the state has negotiated and has actually created a fair amount of laws, like the prompt pay law, the timely claims submission law that I talked to you about in terms of when claims have to be submitted to plans. Those have been set by statute, and the statute really sets the minimum standard that has to be in place, and providers have the right and the ability to negotiate kind of more protective provisions for them if they so choose. And the Provider Contract Guidelines set forth a lot of those provider and consumer protection laws that New York State has in place. And you can find those on the document on the Department of Health website. It's called the MCO Provider Contract Guidelines. You can also just Google it, New York State DOH Provider Contract Guidelines, and that document will come up. And that would be the first place I would start.
Okay, we have a few more questions that have been typed in. This next one is about claims. So what's the general reprocessing or corrected claims time frame?
For corrected claims time frame, that's a good question. I don't know that that's actually set in statute, but I would think that you would want to follow the same. So if you have a claim, you submit it to the state, or I'm sorry, you have a claim, you submit it to the plan rejects it. I think you would go back to probably the claim submission time frame. So you'd probably want to submit it within 90 days again. Again, the longer you wait to resubmit a claim, the longer it's going to take for you to get paid. So, and typically contracts will try and have a cutoff time for, no claims after a year or no claims after 2 years can be resubmitted. So sometimes contracts will say that, but again, it's really a negotiated provision.
Okay, so this next question is, how much can I push back on the contracts the plans give me? Lots of times they seem like it's a take it or leave it situation, or at least that's how they're presenting it to us.
Yeah, understandable. The you know, it's a contract negotiation, so it's all about the leverage that you have. You know, as a small business, you may not have a lot of leverage. There are certain provisions that the plans have created systems operationally that are going to be difficult for them to change, but there are situations where you can push back on that. So I think, you know, it's a matter of kind of really finding out what's most important to you and pushing on what's most important to you based on the leverage you have.
Okay, thanks. We have another question waiting in the wings for you, but I just want to remind folks that they can use the chat box, and they can also raise their hand, and we can unmute you if you want to speak to me directly. So this question is about credentialing. I see that it's taking a really long time with some managed care organizations to get the credentialing process done. What can I do to speed this process along?
Well, by state statute, they're supposed to be credentialing within 90 days, and if it's taking more than 90 days, I would think that you want to kind of let them know that you're aware of what the law is and see if that helps. Otherwise, you can always complain to the Department of Health. They do have a complaint line, and they will follow up to see, particularly if there's a certain plan that is kind of routinely always late in getting the credentialing done. You know, they can then make the plan enter into some kind of corrective action. So there is the Department of Health complaint line, and you can use it.
Okay, another question is, this is about resources. Are there any resources that you're aware of for us to get new information, excuse me, for new information on what's going on in relation to managed care and payments?
Well, again, I think the best thing to do is to look at the Department of Health website. You can also sign up for different listservs on the Department of Health website. There is a document called the Medicaid Update, and that comes out on a quarterly basis and really talks a lot about some of the operational rules that providers need to adhere to or follow for fee-for-service, and a lot of those rules also apply for managed care. So I would suggest signing up for the Medicaid Update, and that'll come to you electronically after you sign up for that. And again, I suggest kind of perusing the Department of Health website. You know, there's a lot of information on there as different product lines are rolling in. I also think it's important to, you know, stay tuned and stay in touch with your associations. So I know NIAPRS and some other associations that kind of help sponsor this MCTAC presentation are invaluable. They're really keeping a pulse on what's happening as Medicaid managed care is rolling out for different populations, and they can be another resource and provide information to you. If you're not a member of them, I suggest becoming one.
Okay, we have another question that was just typed in. For new small businesses, are there best practice resources available? So Whitney, before you answer, I just want to put a plug in for the MCTAC website. If you go on MCTAC.org, there is actually a link for best practices. So that's something that you should be sure to check out. But Whitney, did you want to add anything to that?
I think you said it fabulously. I think that's MCTAC's a great, there's a lot of amazing, really good resources there. So, yes.
Okay. So it doesn't look like we have any other questions that are being typed in. If we want to take, maybe we should take a minute or so just to give people one last chance to use you as one of our really valuable resources, Whitney. And again, I think people are shy. They don't want to raise their hand today. It must be the cold weather. So let's just give everybody another minute or so to regroup and think about some questions. And then we'll close out for today. Okay, so it doesn't look like anyone has any other questions. So I just want to remind folks, though, that if you do think of any questions, as you see on your screen, you can send those questions into mctac.info@nyu.edu, and they will come my way, and I will be sure that your questions get answered. So again, I just want to thank you, Whitney, for presenting with us today. I know that this information is certainly valuable to lots of folks, especially those that don't have as much experience billing Medicaid, so I want to say thank you.
You are very welcome, and if anyone has any questions, feel free to reach out to me directly, or you can get them to Daniela, and she knows how to get a hold of me. Thank you for everyone's time.
Thanks so much, Whitney. Thanks, everyone. Have a great day.
Happy holidays.